Just as a reminder, the major binding proteins in the body that bind drug are, first of all, albumin, which is the most important one. It's the largest. It's the one that has the most drugs that bind to it. And then alpha-1 acid-glycoprotein, or what we call AAG, which is an acute phase reactant. And then finally lipoproteins, and they're in the order of their importance here. Albumin mostly binds acid drugs, although it can bind both. It also binds both bilirubin and cortisol, endogenous compounds. It has a relatively large capacity that stays pretty consistent. It can be, usually in most cases, if you'll see a difference, it's hypoalbuminemia, which you'll see in older people, people with poor nutrition, people with chronic disease. And in that case, you have a decreased capacity, then you're going to have less binding. What that means is a higher free fraction, which is a higher fraction of active drug. There's also, you can have changes in affinity. There's going to be competition for those binding sites, so you can have displacement by a drug that has a higher affinity, so a drug can be displaced. And also the site itself can change. In renal failure, the albumin sites change a little bit, so the affinity does change. You can also see concentration-dependent binding in the therapeutic range. What that means is that you can overwhelm the system with drug, and if you do that, then you're going to have, as the concentration increases, your free fraction will increase. Usually your free fraction will stay consistent, but in this case it can be concentration dependent in the therapeutic range for valproic acid, which is an antiepileptic, salicylates, nonsteroidals, and thiopental, which is an analgesic, anesthesia agent. The second most important is alpha-1 acid-glycoprotein, or AAG. It binds more base and neutral drugs. Its capacity can change drastically. It can change, having 4 to 5-fold increases in times of injury or times of trouble. So when your body is acutely stressed, like if your patient has surgery or a myocardial infarction or a stroke, or is fighting cancer, has rheumatoid arthritis, or other diseases where your body will consider it under stress, you will have an increase in this binding protein. Inflammation is another one. So, and AAG also has a higher affinity in general than do drugs that are bound to albumin. The displacement may be buffered by albumin. So if another drug comes along and displaces a drug from AAG, it's likely also bound by albumin, so you might not see as drastic a change. Lidocaine and disopyramide are both will possibly undergo concentration-dependent binding in the therapeutic range, so nonlinear binding in the therapeutic range to AAG. Finally, lipoproteins mostly bind lipophilic bases and neutral drugs. The capacity depends on what their lipid status is. There's no competition, so you don't really have to worry about a drug being displaced. There's no concentration-dependent binding. Examples of drugs that are bound to lipoproteins are Probicol, cyclosporine. This one's probably one of the more critical ones. Cyclosporine is used as an anti-rejection drug, and for transplant, it's an immunosuppressant. Propranolol, beta blocker, digoxin, tetracycline, and quinidine, but cyclosporine is probably your most important one, where you could see some serious drug interactions. Okay, that's it for this one.